Alrighty, great. Yeah, so again, this is the Nimble Knee. So we're going to talk about, or I guess we'll talk about what we're going to talk about. And so here are the things that we'll cover. I'm assuming that everyone can see the screen that we're sharing now and can see the presentation. I can see some nods there, perfect. Wonderful. So yeah, we'll cover again some common types of knee pain. Some contributing factors to some of those common types of knee pain, strategies that you can try on your own, again, to address any knee pain that you might have, or to keep a healthy knee even if you don't have any pain. When to seek an expert opinion, when to apply heat versus cold, and then sort of what next steps to take, again, if you do happen to have any pain or if you're concerned about potentially develop any pain or dysfunction in your knees. So to give you a little background on knee pathologies in general, say the estimated amount of people that deal with knee pain is about 25% of adults. I think it actually stems from arthritis specific studies. So that's more specific to arthritis related. So it doesn't necessarily account for all knee pain at some point in someone's life. People are saying for arthritis, about 25% of adults deal with some knee pain related to that. Knee pain generally accounts for about 4 million primary care visits annually. So again, a relatively common problem. The knee is commonly referred to as the victim joint due to the contributions of the hip and ankle to knee pathologies. So a lot of times we don't necessarily blame what might be irritated to the knee because it might be caused by something else besides the knee. And then about 7.8 million adults with knee arthritis has significant limitations with kneeling, bending, and stooping, which again are things that most people are going to have to do throughout a normal day. So that can be pretty impactful to someone's day-to-day life. All right, so we have here is kind of some common types of knee pain. What we differentiated those out into is some of the different structures that could get irritated. So as we talk about sort of bony pathologies, so that's going to be kind of grouped into arthritis. Sometimes you have these bone swelling, stress injuries, stress fractures, things like that are kind of in our bony category. We have more cartilage-based pathologies. So that's anything related to the meniscus. Again, sometimes there are other defects in cartilage that can cause irritation, both of the what they call the tibiofemoral joint, being the sort of larger bone here that then is being the femur that's on top of the tibia. So that's the major, we call it the knee joint. And then we have the kneecap joint, where the kneecap sits on top of the femur. So cartilage is between those two different surfaces, between the kneecap and the femur, and then between the femur and the tibia. And that all can get irritated or involved in different knee pathologies. Other than the cartilage, we have ligaments. So you have the, I think probably most commonly known, the ACL. We also have the PCL. So the ACL is just sort of crossing X ligament here in front. The PCL is behind it. They both limit sort of a forward and backward translation of the tibia on the femur. And then we have the MCL and the LCL, so the medial collateral ligament and the lateral collateral ligament. Again, they prevent the knee from displacing sideways as you're moving. So a lot of times, especially with professional athletes, you'll see a lot of injuries to those ligaments as you go through some high force injuries, impacts, and things like that. So other than the, again, ligaments, we also have the muscles. So muscles, again, is seen here on the left image here. So we have the quad. So quad's made up of 4 muscles. We also have the adductors on the inside of the leg here. What's not shown in this picture is, again, kind of the backside of the knee and the hamstring. And then it's not shown also below in terms of the calf and some of the other muscles here, which just by themselves, the muscles can be the primary generator of knee pain. Or they can be involved with something else. Most often, you're going to have some overlap of these different structures. So whether it be bone, cartilage, ligament, or muscle, it's very rarely going to be just one specific structure. And even if one's the primary generator of what you might feel, a lot of times these other structures are involved in some manner. So again, it gets complicated. I think it's of what should be a relatively straightforward joint kind of just functions as a hinge. We wouldn't think it'd be that complicated, but there are a lot of things that go on, and especially as we compound of what could be involved as we look at the hip and the ankle. Show our next slide here. There we go. So if we're looking at risk factors for developing knee pain. So this is going to be important for anyone trying to either, again, avoid developing any sort of knee pathology or knee issue, and or trying to lessen the impact of a painful knee condition or lessen the pain that you have generally. So we talk about risk factors, age and degenerative changes. So again, there's certain parts of these risk factors that are modifiable and certain ones that aren't. Again, age, degenerative changes just by themselves, not really a thing that you have much control over by itself. And again, we sort of expect to see, as you look, let's say, at an x-ray of a knee, as someone ages, we expect the space to narrow a little bit. We expect to see some of the, what they call age normative changes and degenerative changes. Usually some narrowing of the spaces might make it a little bit stiffer, might make it a little bit of that cartilage cushion a little bit less. Again, so but not really anything you can control by itself. So next factor here would be physically demanding career. So again, if you're on your feet a lot, if you're doing a lot of walking, running, a lot of bending, stooping, that can all, again, attribute to knee pain. But again, to some degree, sometimes it's not so modifiable. So again, we'll kind of focus in terms of prevention, on some of these more modifiable risk factors, which takes us then to some of these other ones, such as poor mechanics. So if we look at sort of knee mechanics, is really important. So we talk about this sort of using or overusing your knee. I think it's much more about incorrectly using it than it's about overusing it. So we talk about, runners who will typically develop maybe some sort of knee pathology over their career as a runner. Again, that can be really mediated with a lot of mechanic work. So if you're using that hinge of the knee as it's supposed to be used, it holds up. I think a lot of times it's more about the mechanics that aren't ideal that then cause more stress to go through a certain area of the knee or certain muscle, ligament, et cetera. And that's what leads to an injury. Another modifiable risk factor is excessive weight. So if you have an elevated BMI, that definitely can contribute to a knee pathology, and then it puts more load through the knee. What's commonly said and compared to is that every pound of body weight adds up to about 4 pounds relative on the knee. So as we talk about some of these conditions, especially more arthritic conditions, I talk about how BMI management can be a big part of the equation of the treatment. So if you think about where a good goal for someone who has an elevated BMI might be to take about 10 pounds off. So if you say take about 10 pounds of body weight off, again, correlates to about 40 pounds. So you're taking a 40-pound dumbbell that you're carrying around with you all day and able to just kind of drop that and not have to add that around. So especially if you think about if you're bending down with that 40-pound weight, if you're going through upstairs, downstairs, et cetera, that can be a big contributing factor. Let's see, otherwise, we have then lack of flexibility. So again, the hinge of the knee wants to be able to hinge. If it's impeded or if that hinge is being sort of put off kilter because of a lack of flexibility, again, that can contribute to some excessive strain and an injury. And then the last thing as a risk factor would be previous injury. Again, not so modifiable there, but it's shown that there's correlation with previous injury to prevalence of arthritis as the knee would age. Let's move on to our next slide here. So before we get into some of the things that you can do, or again, these are factors related to knee pain, I wanted to share some signs to seek care immediately. So if you're having any of these particular conditions, it'd be something that you would want to get checked out immediately. And we're talking about sort of immediate care, et cetera. So again, this would be kind of inability to bear weight on the leg. So if you're not able to walk on it at all, that would be signs to go get it checked out immediately. If you have severe pain, swelling, or instability, so such as a dislocating knee, something like that, something that's more significant, again, it would be a sign to seek care immediately. Otherwise, some of these signs of joint infection would also be a sign to seek care immediately. So the presence of, I guess, new onset of knee pain associated with fever, swelling, redness, limited motion. Let's see. So as we talk about the knee being the victim joint, then we get to that second level question of then who's to blame? So do we blame the knee for what's going on and what you might be feeling at your knee? Do we blame the hip or do we blame the ankle? So it's a good question and takes some problem solving to figure out, and everyone's gonna be slightly different. But we'll talk about sort of what we're considering when we look at the hip and ankle. So if we're looking at the foot and its contributions to the a painful knee and what might cause some strain on the knee, although again, it's not necessarily the knee's fault, would be foot and ankle. So if we look at this image on the left, we talk about a collapsing arch, which is also called overpronation of the foot. So we see this arrow kind of pointing in, where then the bones of the inside of the foot and the arch would drop down toward the ground. What happens then is the tibia here also turns inward, as shown with that arrow, and then the knee falls inward as well. So now you have your hinge that's supposed to hinge back and forth, and you've now put a kink in it. There's gonna be more stress on the outer portion of the knee in terms of the bones. There's gonna be more stress on the inside of the knee in terms of the ligaments. So again, as we talk about some of the things we might do for a knee, a lot of times we look at the ankle and see what can we do to stabilize the foot. Do we look at possibly adding an orthotic or something like that to give you extra support, which can be an important piece of the puzzle. The other factor in terms of the foot and ankle could be a higher arch. So it'd be kind of the opposite of this image, where the foot is actually more on the pressure going through the foot is more on the outside of the foot through the smaller bones here. Generally speaking, that's just going to lessen the shock absorption that you might have. So the arch is a really good shock absorber. If we talk about the leg in terms of springs, it's the first spring in the series of springs that you have between your ankle, your knee, and your hip before you reach your back. So this is also we start to talk about in terms of contributions from the foot to, let's say, lower back discomfort as well. So we want to make sure that you're not sort of if the arch is really high, or if you happen to be supinating and going the opposite direction of that arrow, shock absorption might be an issue. So if you're a runner and have a high arch, it might get a little more impact through your knee that you might want. So we want to address that as well. In terms of the hip, again, we talk about a lot of these hip stabilizers, which also will control the hinge on that knee, but again, from the hip up here. So on the right, we see an image of someone balancing on one leg, but you could also look at this as if someone were to be running. So if we look at runners, especially if we look at this where, like, I'm looking at someone from behind, I want to see that this sort of shelf here is level, that you can balance something on either end and it wouldn't fall off. That means that the hip stabilizers are doing what they're supposed to do. So specifically, this gluteus medius muscle is one that we target often. Because of its important contribution to hip stability. So what we look at here is, again, a level shelf there, and then knee is sort of straight in line with the hip vertically down. So that's what we would like to see. What we often see is something more, again, this is relatively significant. You don't necessarily always see it that significant of that shelf tilting to the left. But when the shelf does tilt, then the lower body makes changes to stay balanced. So what you see is that knee start to drop inward. So you now have this sort of inward angle from your hip to the knee on this person's left side, and then have this sort of same, again, tilt of that hinge. So your hinge is not hinging straight up and down anymore. It's slightly canted, a little more stress through the outside. So again, important factor with something that we assess with anybody comes in knee pain. I will typically look at their foot and ankle, how they stabilize, also look at their hips and see how they're stabilizing there. Because a lot of times the treatment can be to fix the cause of of what might be causing knee pain, really might be outside of the knee. think we definitely want to do things at the knee itself to treat what you might feel there. But to actually fix the underlying cause, a lot of times is looking at the other associated areas of the hip and the ankle, and occasionally the knee. All right. So we have, again, it's a couple things you can do in terms of preventing knee pain and any irritation or development of further irritation of a knee. So as we talked about in terms of risk factors, these associate to the modifiable risk factors. So again, we want to maintain a healthy weight. Talk about that sort of elevated BMI and how that 1 pound of body weight correlates to about 4 pounds of excessive strain through the knee. So if we can drop that dumbbell as you're walking upstairs, again, typically feels better. Number 2 would be cross training. So it's especially for, I see a lot of cyclists and runners and people who walk in, bending, just do daily activities as well. So it's trying to use your muscles how you would not normally use them, especially when we get into something as repetitive as, let's say, cycling or running. So if you're always moving forward in those directions, you're going to get really good at moving in that same direction that you practice moving. We want to practice moving these other directions. So you use different muscles, develop good ankle stability, good hip stability, and again, lessen the likelihood for any knee problems. Number 3 relates to our risk factor of sort of faulty mechanics. So we want to say it's not necessarily more practice, but we want to practice perfectly. So it's good to know your tendencies in terms of where you might stray from perfect form, and again, have a plan to sort of work on that. And then continuing to practice perfectly once you get that plan. Number 4, be staying strong or get strong and stay flexible. So again, we want to strengthen all those stabilizing muscles. We want to strengthen all the muscles surrounding the knee. An important part about keeping the knee joint itself happy is, again, having nice stable musculature around it. We also want to stay flexible. Make sure that, again, that hinge can move unimpeded. And then the last one is avoiding injury. Again, so easy to say, harder to do in certain situations. Obviously, sometimes stuff happens, but if you can avoid it, and really these things that we talk about in the beginning, so our 1 through 4, are things that will help you avoid injury. But again, obviously there's some situations where just things happen. All right, so we have, again, sort of why would you seek out a physical therapist for some guidance in terms of a knee discomfort or a concern, etc. So I think the reason is because it's a great one-stop shop for most of your knee concerns. So we'll be able to determine what might be causing your knee pain, or give you some steps as to what to do if we can't figure that out. We'll be able to figure out what contributed to the injury itself. So talk about the hip, the ankle, the knee, and some of these other structures, trying to figure out, not only what's irritated, but why it happened. I think if we address the why, we get a better resolution and are more likely to not have it recur. Try to figure out some strategies for relief. So again, a lot of things we do initially more directed at the knees, trying to give you some relief of what you might feel there. Or troubleshoot ways that you can move that might be, like, say, painful movements that you do that we can figure out maybe a slightly different way to move that would be more comfortable. Again, fix the issue or learn the next step. So again, fixing it or figure out what are the next steps you should take if we can't fix it. If we're looking at then things that we would do, so things that you might expect if you came in for physical therapy for a knee. So manual therapy, so you kind of these hands-on skills, which many of you see here. Many are shown here in the images to the right. So we have soft tissue mobilization, instrument-assisted soft tissue mobilization. So whether it be kind of massage work or massage work with the tool is shown in that lower left picture. Dry needling, which is shown in this upper left picture. Again, it's a method of trying to release a tight muscle, a pretty effective and quick way to get a muscle to loosen up and release. Joint mobilization manipulation, as we see in that image on the lower right, again, trying to make that hinge and the bones of the hinge move the way they should. Flexibility and stretching exercises. So again, giving you some guidance on, I think it's guidance of what muscles to stretch and what to strengthen, but it's also prioritizing it. So I think it can be overwhelming to get the long laundry list of, here are all the muscles you need to strengthen, here are all the muscles you need to stretch, which most often is, most people would benefit from a lot of strengthening exercises and flexibility exercises, but reasonably, can you get that all done in the same day? And I think most often the answer is no. So it's about prioritizing, you know, what's most important, what's most impactful for what you're feeling, and getting that sort of game plan, and also sort of the progression, right? So like, what do you do after the muscle's now loose? Like, what's the next priority? So we give you some guidance there. So strengthening, sorry, I was incorporating that with the last one, but strengthening as well. So something slightly different in stabilization, muscle recruitment. So strengthening, I think we say, okay, we want to get you strong muscles. So we give you an exercise that focuses on that muscle, gets it nice and strong. So I think the second piece, which relates to this topic, is, okay, how do you bring that strength into something that you would do throughout the day? And that's where we talk about more, we'll call like motor control drills, or this like muscle recruitment activities. So it's like, okay, how do you use the strength you've now gained to bring it into daily life? Just having strong muscles doesn't necessarily, you're going to use those muscles in the right manner all the time. So we want to work on that as well. Gait training, so again, just working on the way that you walk, especially with runners, but again, walkers as well. Just movement is important. Like we talk about mechanics, like so gait training is a big part of the mechanics side of things. And then education, so talking about some things that you can, you know, can do, not do, the sort of, again, the series of progressions of how to address knee pain. All right, as we get into kind of the times, when to use heat, when to use cold. So it's a, unfortunately, a more complicated topic than I think it should be. So if we kind of break it down to its basics, although again, there's a debate on the topic, we're saying heat to warm up, cold to cool down. So before an exercise, before a routine at the beginning of the day, heat to warm up, to get ready for the day, cold afterward. So after the activity, after the day, to lessen inflammation and to like cool down. Again, there's some debate in that topic, especially as we start to talk about like an acute injury. Let's say if you sprained a knee yesterday, you know, I think we tend to then recommend more the cold treatment. If it's a little bit more chronic of an issue, again, cold might not be the answer, and it might respond better to heat. So I think at that point where we get further away from or of a new injury, the line gets a little blurred, but I think it's worth to try both. But again, at the basics, we'll say heat to warm up, cold to cool down. And here are some sort of precautions in terms of using heat or cold, both. So want to limit the time to about 20 minutes, whether you're doing heat or cold. You want to use layers between the source just to make sure that, again, you're not giving yourself any burns, or whether it be like a heat-related burn or a cold burn, and avoid sleeping with heating packs to avoid burns. All right. So another thing that you could think about, and again, I think we're as a specialty, I think that nutrition and rehab is going to become more integrated. Right now, it's not as common to see that, but I think we'll start to see. I think that'll be probably the next step with facilitating someone's rehab is going to be talking about the connection between diet and recovery. But so just to give you some general advice in terms of diet, so we're looking at wanting to try and eat foods that would positively impact inflammation. So again, this is sort of like some antioxidants, basically. So whole fruits, especially berries, dark green leafy vegetables, nuts, legumes, and whole grains. Again, potentially omega-3 fatty acids, which can also help with some nerve-related conditions or nerve health. So again, we're trying to say, basically, it's eat these foods that are anti-inflammatory in nature, and then try to avoid foods that are inflammatory in nature. So again, let's talk about more processed foods, red meats, saturated fat, added sugar, etc. Which again, I know is easier said than done. And it's found in terms of committing yourself to a program and incorporating this. It's found that people are more successful when they aim to add the good foods rather than necessarily avoiding the bad ones. So even if you have some processed foods, some added sugar, it's like say, okay, that's okay, but then try to at least get some other foods in the diet that also promote an anti-inflammatory effect. Again, I think online is a great resource. Like if you just Google sort of anti-inflammatory foods or what foods to avoid from an inflammatory side, you can get more specifics there. Let's see, stairs. So I think stairs are a big thing I talk about with almost everybody I see related to knee conditions. So it's going to be either whether going up or down. But most people that have knee issues are going to have some limitation in stairs. So here's a quick, what a pain, right? Because it's commonly a pain. So if you have pain going upstairs, one of the tips that I give that tends to be probably most impactful is you're thinking about your entire foot going on the stair. So this picture on the right is actually the bad example, which his foot got cut off just a tad, but you see his heel's off the edge of the step. And he's somewhat leaning, he's not leaning forward as far as some people do, but he's leaning forward slightly. And this is where it gets the recommendation of going up the stairs and not forward the stairs. So we don't want to do this. We want to go more directly up and put our whole foot on the stair with an emphasis on a push through your heel. So the picture down here is a little bit more indicative of what we're trying to do. So again, depending on the depth of the step, you're going to try to get as much of your foot on the step as you can. Again, even this image, like so his foot's slightly off the back. But so you want to kind of get the foot completely flat on the stair, as much foot on the stair as possible, and you're going to push up through the heel, and you're going to go straight up toward the ceiling rather than leaning forward, which I think most people end up kind of leaning more forward. So we're thinking just going up rather than forward. Again, related to pain, if you have any pain going up the stairs. So if you have any discomfort going down the stairs, we look at a couple different things. And again, this is just sort of a net, so a loose net to catch a lot of things that might relate to pain going downstairs. But again, if you have consistent pain going downstairs, I think it's best that you get it assessed. But generally speaking, stretching out your calves can be an important, it's an important muscle group to keep loose in order to not over stress your knee as you go downstairs. And so if that fails you and it still continues to bother you as you go downstairs, one thing you can try is going down backward. I'd say if you are going down backward, make sure there's a handrail just because it's a little awkward to start doing. Again, just puts a little less stress on the knee, relies on slightly different muscle groups to go down the stairs rather than going forward. So it's something to try. And then in the later on, I'll give you a home exercise program to try out with some very general exercises and stretches you can do for a knee. And then the calf stretch is a part of that. So if you're looking at like what stretch should I do for my calves, that'll be in the program at the end. So we talk about other lifestyle factors that you can do to address knee concerns. So exercise generally, so we're looking at, again, well-tolerated, low impact, moderate activity for about 150 minutes per week. So if that's, we start talking about some of these, let's say something like a knee arthritis that's irritated by these more impactful exercises. So it might take running out of the equation, but a bike's a good option, always a little less impact there. I think if the bike's not well tolerated, then a pool is always a great option where you get that offloading effect of the buoyancy of the water. But even could try something like an elliptical and some other kind of cardio equipment that replicates kind of elliptical or like a stepper machine. But I would say like a seated stepper is another good option for these low impact, moderate, vigorous activities. Also wanted to try to say, resistance exercise a couple times per week, if possible. Again, I think that's where a PT can give you some guidance in terms of what exercises to focus on regarding those resistance exercises. And flexibility exercises, again, it's a long list if you look at all the muscles you could stretch. So I think it's good to get that guidance of what muscles to prioritize based on what you're feeling. So the next steps that you should take, if you have any concerns of knee pain, if you have knee pain, if you've had knee pain and it's not getting better, here are some next steps that you could take. So you could schedule your complimentary physical therapy consultation to discuss your situation. Again, talking about that sort of one-stop shop that will hopefully help you. which again, I'll reach out to everyone via email after this and give you a link, and reach out to schedule a complimentary consultation. Again, just to, if you have any specific concerns or would like to, any general guidance. We're going to control modifiable risk factors like we talked about earlier. I want to initiate a cross-training routine, again, kind of move in different ways, challenge other muscles that you might not normally challenge to make sure you have a nice, stable, steady knee. And then here's the program that I'm talking about, which I'll also send out with the link and schedule request for anybody looking to do a screening. But I'll give you this, which is our, we use a software for home exercise programs called MedBridge. So if you use that URL link there and type in the code, it'll pull up a very general exercise program that you can try for a knee. So it incorporates some strengthening exercises of those commonly affected muscles, some stretches of those commonly affected muscles from a tightness perspective. Alrighty, so see if there's any questions, which I know I had one question before the presentation, which I'm going to stop my share here so I can see everybody if they're here and look at the chat. So yeah, if you have any questions, feel free to and put it in the chat. Otherwise, I did have one question which I'll start to answer, and feel free to enter anything to the chat in the meantime. But the one question I did have was related to cycling on a recumbent bike. So the issue someone brought up was having some pain in their knee as they're biking, which again, this is a good example because, so we talk about the bike being a good method of getting the exercise for someone who might have a painful knee. So say, okay, well, what happens when you start to have pain while you're biking? So and again, which is such a good question. What I would say for, again, talking about very generally in terms of bike setup, and if you're having any knee pain when you're biking, would be that if pain is generally on the outside of the knee, so if you're, as you're cycling and the pain's on the outside of the knee, typically that means you're reaching too far for the pedal and the seat needs to come closer. So you need to be closer up if you're gonna have pains on the outside of the knee. If pain is on the inside of the knee, or we'll say kind of within the knee itself, I would say it's like kind of all encompassing to the knee itself, typically that would mean that we need to get you a little bit further away and you might be going into a little bit too much bend. And that's a very, very general recommendation in terms of bike fitting. I'm actually the person at our clinic here that does bike fits, and we have initiated relatively recently, we started to do some virtual bike fittings. So we're over Zoom. This is for a lot of clients that happen to have at-home bikes, whether it be a Peloton or a recumbent bike or et cetera. And we actually do a sort of a fitting over a telemedicine call. So that would be a potential option to get more specifics. But again, I would think that just as a first level, it's a little bit closer. If it's pain on the outside of the knee, if it's pain in the knee generally or on the inside of the knee, to get a little bit further away. And usually we're talking about just minor changes for bike fitting. We're talking maybe most times, especially if I'm looking at a cyclist who's on a road bike, we're looking to make changes that might be in the like centimeters are big changes. So we look at millimeters to centimeters being like pretty drastic changes. Yeah, so good question. So if you have pains after a bike session, so a lot of times if we took a look at knee pain generally and timing of symptoms, we start to think about what structures are involved. So generally speaking, if we look at something that you feel while you're doing it, it's going to be a structure that gets really good blood flow, and you're going to get more acute feedback. So let's say muscles will give you really acute feedback. If it's a muscle that's irritated, it's going to let you know right away. If it's a ligament, cartilage, or let's say the bone, it typically takes a little bit longer. So let's say if you've done an activity and it's afterward that it feels sore or painful, okay, so we start to think about those structures being involved in the irritation, and it likely means that at least one of those structures has been taxed too much. So I think, one thing you could try would be lessening the time or potentially the resistance of the bike. If you've already sort of gone that route, then I would suggest to, again, kind of get the consultation to get a better, to more specific recommendation. So also for biking, which might pertain, is wanting to maintain a pretty good cadence. So we're talking about like how fast the pedals are moving. So as we talk about biking being this sort of low impact exercise, we want to make sure that the pedals are continuing to spin and it's not a jerkier motion. So it's not boom, 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 but it's a nice cycle, right? So that's the idea there. So sometimes people go too heavy with their resistance and start to end up going more, it's a jerkier contraction or a jerkier motion. We're going to see that's nice and smooth so that the resistance is low enough to facilitate that smooth cylindrical motion. Any other questions at all that anybody has? And then again, I'll reach out to everybody in terms of scheduling or giving the opportunity to schedule a complimentary consultation, which we could talk about anything more specific in detail if you'd like. All right. Well, I appreciate everyone tuning in. And again, if you have any questions for me, feel free to reach out to me. Again, you'll have my email as I send an email off to you all. And have a great rest of the day. And if you're in Chicago, then I hope you're dealing with the snow all right and it doesn't give you any issues. All right. Take care. And Susan, yes, I'll send out the link for the exercises as well. Yep.